Good morning, ladies and gentlemen. The topic of today's lecture is part 2 of the disorders of lymphatic vessels. It was a large chapter, a big chapter, so I decided to split it into 2 lectures. And even then, the lecture number 1 was quite long. Let's see in what time can I finish this lecture. So let's proceed. The first disease we are going to discuss today is the primary lymphedema. The primary lymphedema arises due to some intrinsic abnormality involving a genetically determined aplasia, hypoplasia, malformation, or dysfunction of the lymphatic vessels. So, primary lymphedema is an intrinsic abnormality. पैदाइशी या शुरू ही से ये डिफेक्ट मौजूद होता है. It may occur as a non-syndromic Mendelian condition and less commonly a part of a complex syndromic disorder. The primary lymphedema due to underlying genetic abnormality should always be suspected in a patient presenting with swelling and no obvious medical cause in those presenting during childhood or early adult years. So, एक बात तो ये confirm है कि primary lymphedema young age में manifest हो जाता है, जबकि दूसरा lymphedema में time लगता है manifest होने में. Primary lymphedema was classified into 3 categories depending upon the age of onset of swelling. Number 1 is congenital, that is lymphedema that is present at birth. Precox, that lymphedema developing after birth but before the age of 35 years. And tarda, lymphedema developing after 35 years of age. So there are 3 types: congenital, precox, and tarda. Mutations in several genes are known to cause primary lymphedema. The first 2 genes to be identified are vascular endothelial growth factor R3, also known as FLT4 in Milroy's disease, and FOXC2 in lymphedema dystichiasis syndrome. The phenotype and genotype of patients with primary lymphedema leads to a better understanding of the natural history and management of specific conditions and more accurate recurrence risk for further generations. So, clinical features. Primary lymphedema usually present at birth or develop later in life. Both is possible, but generally early age में manifest हो जाता है. One or more limb may be affected, or indeed there may be a generalized whole body swelling, depending upon the subtype of lymphedema which we are going to discuss. The clinical signs of lymphedema range from mild swelling to grotesque grotesque enlargement in chronic and poorly managed patients. So, थोड़े से लेके बहुत ज़्यादा swelling भी हो सकती है. The protein-rich materials, lipids, and debris accumulate in addition to water, जो होता है. This results in solid and fluid components of the swelling, giving rise to the brawny nature of chronic edema that resists pitting. So, the lymphedema, especially the primary lymphedema, present as a non-pitting edema, or the nature of the swelling है वो ज़रा hard type swelling है क्योंकि उसमें solid और fluid दोनों components मौजूद हैं. So the skin changes of lymphedema, like all the other lymphedema, comprising of the brawny fibrotic skin and the presence of Kaposi stammer sign. Kaposi stammer sign, you all know, is that if you try to pinch the skin of the second toe, then it is you are unable to pinch the skin. Lymphangiosis appear as small blisters on the skin surface. as a result of engorgement of lymphatic vessels. And lymph fluid frequently leaks as a result of minimal trauma. This results in lymphoria. So, in additional changes of primary lymphedema or other lymphedema of chronic nature are lymphangiectasis, जो कि small lymph blisters होते हैं skin पे, and lymphoria, which is the leaking of lymph through the skin. There are 5 major clinical variants of primary lymphedema. The first is the syndromic form of lymphedema, then localized or generalized lymphedema that is associated with systemic or visceral lymph abnormalities. Then the lymphedema which is associated with disturbed growth or cutaneous vascular anomalies. Then lymphedema that is present at birth, that is present at birth or develop after within few years of life. So early onset lymphedema, then late onset lymphedema that develop after the first year of life. So there are different types. We are discussing these in further detail now. The syndromic primary lymphedema is a recognized feature of many syndromes. That is, it is a part of a syndrome, or commonly a syndrome say Turner and Noonan syndromes. Then primary lymphedema may be associated with systemic or visceral involvement. Lymphatic dysfunctions may present prenatally with hydrocele or hydrops fetalis. The development of in utero edema may cause dysmorphic facial features such as epicanthic fold, broad nasal bridge, neck webbing, and low set ears. There may be pericardial or pleural effusion, chylous ascites, pulmonary and intestinal lymphangiectasis in postnatal period. So these are all the examples of lymphedema with systemic or visceral involvement. And management include drainage of effusions and implementation of medium chain triglyceride diet to manage intestinal lymphangiectasis and chylous disorders. Lymphedema is also associated with disturbed growth or cutaneous vascular abnormalities, as we see in association with Proteus syndrome, Klippert-Trenaunay syndrome, and Clough syndrome. We have discussed these syndromes in previous lectures. Then congenital multisystem lymphedema. These are the patients that have asymmetrical pattern of lymphatic failure with some limb sparing, that is, some limbs are unaffected, but without overgrowth or cutaneous or vascular abnormalities. There is a syndrome which is called as the Wild syndrome. And Wild syndrome comprises of warts, immunodeficiency, multisegmental lymphedema, and anogenital dysplasia. Late onset primary lymphedema. The term late onset primary lymphedema is, as the name signifies, is a primary lymphedema that develops after first year of life. This section contains number of assorted conditions, some of which may be life-threatening, like Amberger syndrome, but they are all share the common findings of non-congenital limb swelling. One of the example is lymphedema diastrichiasis syndrome. This condition presents with pubertal onset of bilateral lower lymphedema with dystichiasis. Dystichiasis is aberrant eyelashes arising from meibomian glands and present in 95% of the affected individuals. Meeks disease is a most prevalent type of primary lymphedema, which typically present as bilateral lower limb lymphedema, but the onset is in adulthood. Amberger syndrome, as we have mentioned before, is a late onset bilateral or unilateral lower limb edema with or without genital lymphedema. Together with myelodysplastic syndrome, and or acute myeloid leukemia, high progressive sensory neural deafness, and severe cutaneous warts. So, Amberger syndrome is a syndrome in which bilateral or unilateral lymphedema is associated with serious blood-borne malignancies like myelodysplastic syndrome and myeloid leukemia. Then the generalized lymphatic dysplasia. This has a more global pattern of lymphedema. Swelling typically affect all body parts and often present in utero with hydrops fetalis. Hennig-Kam syndrome is an autosomal recessive generalized lymphatic dysplasia, present with lymphedema of all four limbs, intestinal and pulmonary lymphatic dysplasia, and variable degree of learning difficulties and characteristic faces, which are flat face, flat and broad nasal bridge, and hypertelorism. Different stages of lymphedema as adopted from International Society of Lymphology consensus document. Stage 0, a latent subclinical state where swelling is not evident despite impaired lymphatic transport. This stage may exist for months or years before edema becomes evident. So stage 0, the problem has started, but it's not clinically manifest. Then stage 1, early onset lymphedema hai, where there is accumulation of tissue fluid that reduces with lymph elevation, and pitting may be present. So stage 1 में pitting होती है और जैसे पाँव उठाते हैं edema कम हो जाता है. But stage 2, the fluid does not reduce on elevation. और later on stage 2 में non-pitting edema भी आ जाता है. So जब elevate करने से edema कम नहीं हो रहा तो इसका मतलब है patient is in stage 2. और जो आखिरी stage है वो stage 3 है. Now in stage 3, fibrotic tissue and absent pitting with elephantiasis skin changes develop. And the elephantiasis skin changes are acanthosis, fatty and fibrous tissue changes, and warty overgrowths. This classification is useful in monitoring response to therapy over prolonged period. So, जो classification है, this will hold for all kinds of lymphedemas. Then classification of severity. The severity of lymphedema may be classified according to the clinical features, and this may be useful in monitoring. ये हमने जो भी कर लिया. Yellow nail syndrome. Yellow nail syndrome is a distinct syndrome that comprises of overcurved, smooth, translucent, slow-growing nails with yellow discoloration. Along with that, there is respiratory ailments such as chronic sinusitis, bronchiectasis or pleural effusion, and lymphedema. So there are three features of yellow nail syndrome. Yellow overcurved, slowly growing nails, then respiratory complaints, and lymphedema. Although listed as genetic condition, it's more commonly developed later in adulthood and as a sporadic condition. Pathogenesis of this condition is unknown, and lymphangiogram abnormalities have been described, although it is unlikely to be a primary abnormality. Clinical features. Patients are usually first aware of not needing to cut their nails. So nail changes are first to manifest. Nail become thicker, harder, discolored, and nail unit may become painful, particularly if affected by paronychia. Then as far as the respiratory symptoms are concerned, cough is the commonest respiratory symptom and it is productive. Then shortness of breath indicate pleural effusion. Peripheral edema usually starts with ankle bilaterally, but it becomes more widespread involving the trunk, genitals, and upper limb if severe. So this picture shows yellow thick nails which are slowly growing, overcurved with the hand edema. The differential diagnosis. Nail changes are not unusual with lymphedema due to secondary fungal infections, because although the fungus causes softer and more friable nail plate. So आपको पता होगा, in case of fungal infections, nail plate is easily sloughed off. वो इतनी hard और tough नहीं होती जितनी yellow nail में होती है. Complications. Recurrent chest infections are the commonest complication. And recurrent cellulitis frequently complicates the lymphedema. Acute paronychia complicate the nail unit changes. Management. Most effective treatment of pleural effusion appears to be pleurodesis or decortication pleurectomy. Lymphedema does not respond to diuretic. Nevertheless, spironolactone may be tried, especially if edema is widespread. Vitamin E is most common treatment prescribed for nail changes, but evidence base of this treatment is weak. The next topic we are going to discuss are the lymphatic malformations and lymphangioma circumscriptum. Vascular tumors are endothelial neoplasms characterized by increased cellular proliferation. Vascular malformations, on the other hand, are the result of abnormal development of vascular elements during embryogenesis and fetal life. So these two terminologies should be differentiated. That is the vascular tumors or vascular malformations. Tumors are the tumors and characterized by increased cellular proliferation, while malformations are developmental abnormalities. The term lymphangiomas circumscriptum has been in common use by dermatologists to describe a lymphatic malformation. Strictly, a lymphangioma should be a growing lymphatic tumor. But lymphatic malformations, once formed, form an abnormal development of lymphatic vessels, grow by expansion and dilatation. So, lymphangioमा तो एक growing lymphatic tumor है, but जो lymphatic malformations हैं, वो growing problem नहीं है. Although developmental abnormalities of lymphatic vessel होती हैं, जो नई vessels तो नहीं बनती, लेकिन जो already बनी हुई vessels होती हैं, वो expand और dilate जरूर हो सकती हैं. Localized congenital lymphatic malformations can be divided into macrocytic, which are deep, or microcytic superficial lesions. So generally, जो superficial lymphatic abnormalities होती हैं, उसमें छोटी cyst बनती हैं, while अगर deeper lymphatics abnormal होते हैं, तो वो बड़ी cyst बनाते हैं. Lymphangimatosis is a disorder of proliferative lymphatic vasculature characterized by progressive involvement of various body tissues and can involve the skeletal system, connective tissue, and even viscera. Lymphatic malformations with few but large macrocytic swellings containing clear lymph is called as cystic hygromas. Hygroma का मतलब है moist or watery tumors. Then such kind of deep lymphatic malformations most commonly occur in neck, but frequently extend into upper mediastinum. And the term tend to be reserved for congenital lymphatic malformations. Lymphangioma circumscriptum is a term that is best reserved for lymphatic malformations that is localized to an area of skin, subcutaneous tissue, and sometimes muscle. So the lymphatic malformation like cystic hygromas हैं, ये deep rooted हैं, while lymphangiomas circumscriptum is superficial, involving skin and subcutaneous tissue. इसीलिए lymphangiomas circumscriptum के size छोटा होता है. Epidemiology: approximately 75% present at birth, while the remainder present as a 2 years of age. The anatomical locations of lymphatic malformation is most frequently head and neck. Pathology: on light microscopy, there is marked expanded channel in the dermis, which can extend into subcutaneous or even deeper tissues. These channels are lined by flattened cells. Staining with D240 may be necessary to make a distinction between blood capillaries and lymphatics. So D240 is the immunostain which is used to differentiate between the endothelial lining of lymphatics with the vessels, with the blood vessels. Pathogenesis of late onset disease. Following regional lymph node excision or radiotherapy, cutaneous lymphangiosis may occur, most commonly over external genitalia, scrotum or vulva. Previous surgery or radiation disrupts the deep collecting channels, leading to lymph stasis, lymph backflow, and subsequently the distension of upper dermal lymphatics. The clinical features: lymphangioma circumscriptum, present at any age, but is usually noted at birth or appear during childhood. So early manifestation. Commonest sites are axillary fold, shoulders, flanks, and proximal parts of limb and the perineum. Clinically, the condition manifests as fluid-filled vesicles, which are also known as the lymph blisters. These are translucent, but may vary in color from red to blue to black when it contains the blood. Usually blood nahi hota, so they appear as translucent. The surface of the lymphangiomas may appear extremely warty, and the lesions are mistaken for warts. So you can see these lymphangioma circumscriptum, they look like warts. If in doubt, if you puncture these lesions, clear fluid extrudes. So this is a very useful distinction with solid warts. Extensive lymphatic malformations can have a blood vascular component as well. Then lymphatic malformations of the neck region often leads to obstruction of upper airway. Other complications include consumption coagulopathy. In particular, low platelets can complicate them. Weeping of lymph or blood, lymphoria, or local cellulitis are other presentations. Squamous cell carcinoma rarely is described arising in lymphangioma circumscriptum. Otherwise, the prognosis is excellent. Investigation: if in doubt, biopsy is done, which will reveal the angulated channels, and you can prove it further by CD31. CD31 is a vascular marker. It will not be able to differentiate between vessels, blood vessels, and lymphatics, but D240 is able to distinguish. Ultrasound also demonstrate the fluid-filled channels. Management: majority of lymphatic malformations are best managed conservatively. Sclerotherapy of microcystic lymphatic malformations using bleomycin is effective and safe. Complete response is seen in 38% and partial response in 58%. Debulking procedure may be necessary for very large malformations that is causing obstruction of vital organs and their functions. Surface vesicles that weep and bleed should be destroyed with diathermy or with carbon dioxide laser. Infections are treated promptly with antibiotics. Second line, sildenafil can reduce lymphatic malformation volume and symptoms in children. And third line treatment for those patients with proven mutations in AKT, PIK3 or mTOR pathways, mTOR inhibitors like sirolimus may prove helpful. So the next topic is lymphangimatosis, lymphangioleiomyomatosis, and non-malignant lymphatic tumors. Lymphangimatosis refers to excessive growth of aberrant lymphatic vessels. There is no clear distinction between lymphatic malformations, lymphangimatosis, and some non-malignant lymphatic tumors. In lymphangimatosis, there is progression in proliferation of aberrant lymph vessels, whereas in lymphatic malformation, there is no progression. ये difference हमने पहले भी बताई है कि lymphangimatosis is a progressively increasing growth, while lymphatic malformations does not progress, but only increase in size is expected as the time advances. Some non-malignant vascular tumors may exhibit lymphangioma-like appearance with positive staining for lymphatic markers. और ये tumors include होते हैं tufted angiomas, Kaposi's hemangioendothelioma, multifocal lymphangioendotheliomatosis, and thrombocytopenia, papillary intralymphatics angioendothelioma, retiform hemangioendothelioma, and acute and adult type hemangioendotheliomas. So all of them are non-malignant vascular tumors. Lung, retroperitoneal tissue, and abdominal organs are most commonly affected by lymphatic malformations and lymphangiomatosis. Now we are going to discuss a few diseases which are associated with these conditions. Gorham disease, characterized by proliferation of lymphatic vessels, resulting in progressive osteolysis. Then generalized lymphatic anomaly, malformation of lymphatic vessels involving multiple sites of soft tissue, lung, abdominal organs, bone. But unlike Gorham disease, it is not progressive. Benign lymphangioendotheliomas present as reddish or bruise-like plaques, usually located on abdominal wall, thigh, and calf. Histopathological appearance mimic low-grade sarcoma or Kaposi sarcoma, but without cellular atypia. D240 and PROX1 immunostains are positive, indicating that it is a lymphatic tumor and runs a long and benign course. Maffucci syndrome consists of diffuse hemolymphangiomatoses accompanied by severe and widespread deformities of bone and cartilages, notably enchondromas of the digits. Kaposiform lymphangiomatosis. Skin involvement resembles diffuse Kaposi sarcoma and lead to lymphedema. Lymphangioleiomyomatosis. A slowly progressive, low-grade, metastasizing neoplasms associated with cellular invasion, cystic destruction of pulmonary parenchyma, exclusively seen in women, especially during childbearing age. This slide shows Kaposi's lymphangiomatosis, and this shows benign lymphomatous papule post-radiotherapy. Few other conditions associated with lymphatics is lymphocele, seroma, and lymph fistula. Lymphocele, also known as lymphocysts, occur when efferent lymph vessels are disrupted and lymphatic fluid accumulates in potential spaces without a distinct endothelial lining. So lymphocele is accumulation of lymphatic fluids outside the lymph without any distinct endothelial lining. When copious lymph fluid drains externally, it is referred to as lymph fistula. So once this lymphocele drains externally, this is converted into lymph fistula. A seroma is a pocket of clear serous fluid that also collected in tissue spaces, usually after surgery. Seroma may be difficult to distinguish from lymphocele. So चूंकि दोनों ही lymphatic से बनती हैं, तो इसलिए they are difficult to distinguish. In case of groin lymphocele, Treatment options include serial aspiration and compression, installation of sclerosing agent, radiation therapy, negative pressure wound therapy, and operative resection of the cavity with or without muscle flap coverage. Lymphangioma or lymphangiectasis. Simple, sustained dilatation of otherwise normal lymphatic vessel is called as the lymphangiectasis. When lymphatics are distended due to structural abnormalities of a tumor-like nature, the term lymphangioma is best suited. Lymphangiectasis can be seen as translucent flat areas in skin which may ooze lymph spontaneously or after trauma. Lymphangiomas consist of dilated lymph channels of various sizes lined by lymphatic endothelium. So we have discussed these conditions before. So this picture shows vascular lymphangiectasis showing acquired lymphangiomas following cervical cancer treatment. And this is easily mistaken with genital warts, just like lymphangioma circumscriptum. Lymphatic filariasis is an important disease to discuss. It is the single largest cause of lymphedema worldwide. It's a parasitic disease and caused by 3 parasitic filarial worms: Wuchereria bancrofti, Bergia malai, and Brugia malai and Brugia timori. Wuchereria bancrofti accounts for 90% of the cases. So the infection by Brugia is rare. Worms are transmitted by bite of mosquitoes. Adult worms live in human lymphatic system and disrupts the drainage, resulting in lymphedema and hydrocele. Worldwide, 120 million people are infected, and 40 million of these have lymphatic problems. Most affected individuals are male and are adolescent or adults. The microfilaria circulate within the peripheral blood and are able to infect the mosquito vectors as they feed, facilitating transmission to other human hosts. The adult female worm may survive for more than a decade and is able to release thousands of fully formed microfilaria into lymphatic circulation of the host every day. The clinical signs are related to adult worms residing in lymph vessels and are not due to microfilaria. The filarial, तो जब लॉन्ग स्टैंडिंग इन्फेक्शन होता है तो बहुत सारे एडल्ट वॉर्म बन जाते हैं और बहुत सारे लिम्फेटिक्स ब्लॉक हो जाते हैं. The filarial parasites specifically target the lymphatics and impair the lymphatic flow, which is critical for the maintenance of fluid balance and physiological interstitial fluid transport. This is the life cycle of Wuchereria bancrofti. The life cycle starts with bite. Start with the bite of a mosquito. We start from number 4. It takes a blood meal, and in the blood meal, the mosquito ingests the microfilaria. In the gut of the mosquito, the microfilaria shed their sheath and gradually penetrates the mosquito midgut and migrate to thoracic muscles like this, and then passes through stage 1 and stage 2 and then stage 3 larva. The stage 3 larva move to the head and reach to mosquito's proboscis. Then mosquito takes a blood meal and releases these microfilaria into the skin. In the skin, this microfilaria matures into the skin. It enters the lymphatics, and the microfilaria mature into the adult form, and then the adult female start laying microfilaria that move into the lymphatics and the blood channels. Pathogenesis of the lymphatic disease. The live worm secretes irritant toxins that cause dilatation of lymph vessels surrounding the worm. This causes a reduction in lymphatic flow, and subsequent edema promotes fibrosis. Then lymphatic damage and subsequent lymphedema also occur as a result of direct presence of adult worm in the lymphatics. These dead worms induce granuloma formation, which lead again to lymphatic outflow obstruction within the vessel. People residing for prolonged period in tropical or subtropical areas where lymphatic filariasis is endemic are at a greater risk of the infection. Repeated mosquito bites over several months are required in order to acquire lymphatic filariasis. Hence, the visiting tourists are low risk of acquiring lymphatic filariasis. So, the lymphatic filariasis is common in the resident population of that area rather than the tourists. The clinical disease occur in minority of those infected with lymphatic filariasis, and majority of individuals have few manifestations despite the large number of circulating microfilaria in their bloods. Most common presentation of lymphatic filariasis is acute adenolymhangitis, also known as ADL. ADL is characterized by sudden onset fever, painful lymph nodes, lymphangitis, and transient edema. Involvement of genitals appear to occur exclusively with Wuchereria bancrofti. Bergia's infection does not cause this problem. In previously asymptomatic individuals, the ADL lasts for 4 to 7 days with tendency to recur. Individuals with established lymphatic filariasis develop more severe and prolonged episodes of ADL. Acute dermatolymphangioadenitis. This is a process characterized by plaque-like lesions of cutaneous or subcutaneous inflammation. That's why it is the term dermato is included, accompanied by ascending lymphangitis and regional lymphadenitis. That's why it is dermatolymphangioadenitis. These features occur in association with systemic signs of inflammation like fever and chill. This condition is thought to result from secondary bacterial and fungal infections in the filarial skin. Then chronic lymphatic obstruction. As a result of filarial worm lead to development of hydrocele, lymphedema, elephantiasis skin changes, and rarely chyluria. The diameter of hydrocele may be significant and reach to the diameter of 30 centimeter. Lymphedema occur as a result of accumulation of lymphatic fluids within the tissue following the lymph vessel damage. And sites most commonly affected are the lower limb and scrotum. Chyluria is a rare complication of lymphatic filariasis, result in presence of chyle, that is intestinal lymph, within the urinary tract. The urine appears milky white in color. Serious nutritional deficiencies may occur as a result of loss of fat and protein with the urine. Tropical pulmonary eosinophilia syndrome may rarely affect individuals with lymphatic filariasis due to Wuchereria bancrofti and Bergia malai. They develop respiratory wheeze and paroxysmal nocturnal cough similar to asthma. This is a patient of lymphatic filariasis. Disease course and prognosis. Clinical course of untreated lymphatic filariasis is progressive skin changes, worsening lymphedema, and increased incidence of secondary infection. Poor quality of life is associated with untreated cases. Elephantiasis and subsequent deformities lead to social stigma, financial hardship, loss of income, and increased medical expenses. So it is quite devastating. Investigation, there is elevated blood eosinophilia and high level of serum, immunoglobulin E and specific anti-filarial antibodies. In endemic areas, adults with lower limb lymphedema or male genital involvement are most likely to be suffering from lymphatic filariasis. A definitive diagnosis is made by detection of adult parasitic worms within the lymphatic vessels or accessible lymph nodes. Doppler ultrasound may detect motile adult worms within the scrotum. The filarial parasites exhibit the nocturnal periodicity that restricts their appearance in the blood to hours of 10 p.m. to 2 a.m. So the typical features of the filarial parasites is their nocturnal periodicity. They come in the blood at night between 10 p.m. and 2 a.m. Hence, to diagnose lymphatic filariasis, it is important that the blood is drawn at this time and the peripheral blood smear are stained with Giemsa or hematoxylin eosin. In recent years, PCR and rapid antigen assays have developed. The antigen test detects infection within minutes and can be carried out at any time of the day, unlike the previous tests. Now we discuss the management of lymphatic filariasis. The strategy proposed by WHO to achieve the lymphatic filarial elimination comprises of two components. The first is interruption of transmission of filarial infection in all endemic countries by drastic reduction of microflaria prevalence levels. This is possible if the entire at-risk population is treated by mass drug administration for a prolonged period of time. This is the first strategy. And second strategy is the prevention and alleviation of disability and suffering in individuals who are already infected with lymphatic filariasis. So the drug regimen that is recommended by WHO to be administered once a year for at least 5 years, with coverage of at least 65% of total at-risk population. And this is 6 mg per kg of diethyl carbamazine citrate, known abbreviated as DEC, in combination with 400 mg albendazole, or 150 microgram per kg ivermectin in combination with 400 mg albendazole in areas where onchocerciasis is prevalent in order to avoid the adverse drug reactions with DEC. So there are two kinds of drug therapies. एक के अंदर डाईइथाइल कार्बामेजीन सिट्रेट है और दूसरे के अंदर आइवरमेक्टिन है. But 400 mg albendazole is present in both. Ivermectin is given in those areas where both onchocerciasis and filariasis is prevalent, while in those areas in which onchocerciasis is not prevalent, diethyl carbamazine and albendazole is the better combination. Lymphedema, elephantiasis skin, and acute inflammatory episodes are typically managed with simple measures of improved hygiene, skin care, exercise, and elevation of affected limbs. Surgical treatment. Male with hydrocele benefit from hydrocelectomy procedures to achieve volume reduction. Lifestyle management that include regular washing with soap and water, use of footwear, and excess of antibiotics and lymphedema treatment. Lifestyle measurement include sleeping under mosquito nets, using mosquito repellents on exposed skin, and wearing long sleeves and trousers. Podoconiosis. Podoconiasis is referred to as development of bilateral lower limb lymphedema thought to occur as a result of prolonged exposure to irritant mineral-rich soil present at high altitudes. These minerals appear to trigger an inflammatory response resulting in impaired lymphatic drainage and subsequent lymphedema. So podoconiosis is not an infection, but rather it is an environmental condition which results due to exposure to a typical mineral-rich soil at high altitudes. Podoconiosis is leading cause of lower limb lymphedema of young people residing in Africa, Central America, and Northern India. Yet it remains to be a neglected condition. This term was proposed in 1980 to describe non-filarial cases of elephantiasis skin, and since then gained widespread acceptance. The term is derived from Greek words for foot podosis and dust konos. Prevalence. Reported prevalence is estimated as 1 million people living with the disease. Typically occur in first and second decade. Gender results are unreliable. Certain occupations with prolonged contact of soil are at risk, like especially the farmers, and it is associated in lower level of income and poor education, unmarried and delayed induction of footwear. So ज़्यादातर उन लोगों में होती है जो farmers हैं, poor हैं और जूते नहीं पहनते. Soil particles that causes this condition include smectite, mica, and quartz. One possible theory is that the irritant particles cause an inflammatory immune response with subsequent impaired lymphatic drainage of lower limb, perhaps as a result of intraluminal lymph vessel obstruction. Podoconiosis present with prodromal phase of pruritus of the forefoot with burning sensation of feet and lower limb prior to the onset of elephantiasis skin changes. Affected individuals develop bilateral lymphedema of foot and ankle region, lymphoria, that is leakage of lymph, hyperkeratosis, papillomatosis, fibrosis, and gross disfigurement below the knee develop if condition remains untreated. Toes develop a characteristic macerated and mossy appearance, hence the pseudonym of mossy foot. And recurrent lower limb cellulitis frequently complicates the clinical picture. This is podoconiasis. Clinical difference of podoconiosis with filariasis. Feet and ankle being the initial symptoms of podoconiosis rather than groin or proximal limb, which are the common site of filariasis. Podoconiosis affect both lower limbs, whereas filariasis present with unilateral lower limb swelling. Groin involvement in podoconiosis is extremely rare. The podoconiosis may be distinguished from leprotic lower limb lymphedema. So in lepers, there will be loss of sensations, trophic ulcers, and thick and peripheral nerves, and involvement of other sites, which is not seen in podoconiosis. Disease course and prognosis. Without access to footwear and conventional lymphedema treatment, condition is progressive, complicated by recurrent cellulitis. Management. The primary prevention of podoconiosis is avoiding prolonged contact between skin of the feet and irritant soil by using good footwear daily washing the feet with soap and water, and use of antiseptics. Simple compression bandage is effective in reducing limb volume. Change in occupation and relocation may be beneficial. Advanced cases are managed by leg elevation and multi-layered compression bandage. Debulking surgery is abundant. Local belief is that there is no effective medical treatment. So I would like to end my talk today at this junction. A small portion of the chapter is still left, but I will cover it in my next lecture. Thank you very much, and thank you for patient listening.